sensitive. Okay. And let's put it on 18 again. Sensitive. Okay. This patient was referred to me for endodontic retreatment of tooth number 8. These root canals were done when she was very young, many years ago, so there was trauma to these teeth, and her dentist at the time did these root canals. You can see there is a bridge on this tooth. This is, according to the patient, this is her 3rd bridge, and this bridge is 4 years old. Recently, tooth started to hurt. There was also a swelling, according to the patient, above the tooth. Her dentist put her on antibiotics, and swelling went away, and patient came to see us for a consultation. So you can see, as I said, there's a 3-unit bridge here, tooth number 8, prefab metal post, root canal here. You can see root resorption and a periapical lucency. That's another angulation of the tooth. That's another angulation of the tooth. Again, you can see that large periapical lucency there. Another angulation of the tooth. And again, another angulation. And you can see the large periapical lucency and apical root resorption there. So some people believe that we should go straight to apical in a case like this, and I completely disagree. Apical will only address the apical few millimeters of the canal, but we all know that we have microorganisms present throughout the entire length of the root canal. So if we're leaving all of these bacteria behind over time, as good as our apical seal will be here, that apical seal over time will break, and patient eventually will develop another infection. So the best thing to do would be to go ahead and non-surgically retreat this tooth, get rid of as much of the microorganisms as possible, prepare the tooth for a future apical if need be by placing an MTA plug here, and bring the patient back a few months post-op and take a look. If there is no healing of the periapical lucency here, then you can go to apical. The tooth is already ready. You know that you've reduced the load, bacterial load here, and very likely the reason for non-healing is very likely presence of microorganisms or biofilm on the outer surfaces of the root in the periapical area. And then that will be taken care of with an apical, usually. All right, so, and that's what we did yesterday. Went through this PFM bridge, removed the post, and this is the post. And of course, remove the gutta percha. I use chloroform. And take a look here. Just wanted to make sure my working length was correct, and you can see this is a 50 file, and I was at 21 millimeters, and you can see I'm short so by about 2 millimeters, so we went to a 23 millimeter file, and this is gutta percha that I was able to remove. And take a look here. And here's the post-op. So as you can see, everything went great. The apical diameter was over 80. And I went ahead and used white MTA. So that's an MTA plug, followed by gutta percha and sealer, temporize the tooth, and refer the patient back to her dentist for the permanent restoration. Ask the patient to come back and see us in 6 months for us to evaluate the healing of this periapical lucency. If there is no healing, then we can go ahead and do an apical here. The tooth now is ready for an apical because there's an MTA here. Apical is much easier in this case.